Hello, I'm Jenny Blakey. I'm the co-chair at EAAA, Elder Abuse Action Australia, and I welcome you here to this Lunch and Learn session. I'd start with acknowledging the traditional custodians, the First Nations of the land on which we meet today, wherever you are, and their continuing connection to land, sea and community. And I'm on Woonwurrung land here in South Melbourne and South Victoria. I pay respect to elders past, present and future, and I extend that respect to any Aboriginal and Torres Strait Islander people here with us today. Welcome to you. We have 147 registrations, which is fantastic. So I'm really pleased to see the interest in this session. And this session is organised in recognition of the 16 days of activism against gender-based violence, which is an annual international campaign that starts on the 25th of November, the International Day for the Elimination of Violence Against Women, and runs until 10th December, which is Human Rights Day. And it calls for prevention and elimination of violence against women and girls, and of course, older women are included in that. I encourage you to become members of EAAA to help tackle elder abuse against older people. And I also encourage you, if you don't know about it, we have a national conference in beautiful Hobart on the 14th and 15th of February next year, which is the National Elder Abuse Conference. And it's a hybrid conference, so you can register and attend virtually, or you can register and be there in person. I'd now like to introduce Professor Briony Dow, who's the facilitator of today's session. And thank you, Briony, for doing this. Briony is the Director of the National Ageing Research Institute, NARI, and Honorary Professor at the School of Population and Global Health at the University of Melbourne. And she's Honorary Professor at the School of Nursing and Midwifery at Deakin University. As Director, Briony leads a range of both aged care and social and clinical gerontology research programs, incorporating her own research and expertise in areas of elder abuse and carer mental health. Thank you, Briony. I hand over to you.
Thanks, Jenny. I'd also like to acknowledge the traditional owners of the country on which I am coming to you from, the Wurundjeri Woiwurrung people. But I'd also like to acknowledge the traditional owners of all the lands and waters across Australia and pay my respects to elders past, present and emerging. So it's great to be here today and to, as Jenny said, have so many people interested in this important topic of the intersection between elder abuse and mental health and wellbeing. We've got a fantastic panel who I will introduce you to in a moment. But we also have a very fantastic and well-considered discussion paper, I should say, prepared by Melanie Joosten from Seniors Rights Victoria, which we're releasing today and which will be the focus of our discussion. I recommend you all to read this report. The link to it will be posted in the chat at some stage, and it will also be on the Compass website, so you'll be able to read it at your leisure. So I think as we better understand the complexity of elder abuse, it's actually really useful to focus in on some of the, I guess, the key drivers, but also consequences. We could have a session on ageism, we could have a session on housing, but I think it's really good to focus in on mental health to really grapple with some of the issues that are experienced by older people, but also some of the issues experienced by perpetrators of elder abuse. Some years ago now, I submitted a paper to a psychiatry journal on elder abuse, and it was rejected on the basis that elder abuse is not a mental health issue. So I think what we'll discover, if we haven't already by the end of today, is that elder abuse is in fact a mental health issue. It's a risk factor for both the older person and the perpetrator, and there are serious mental health consequences as a result of elder abuse. So we'll tease these issues out as we go today. And so I'm going to start by asking the panel some questions once I've introduced them, but you're also welcome to join in. So there's a Q&A symbol at the bottom of your screen. So please, if you would like to ask a question, click on that and submit your question. And I'll keep an eye on that, or Katie will actually from EAAA will keep an eye on that for us. And we'll try to get to the questions. But if we don't get to them all in this short session, we'll certainly look at them later and do some written response, which will be on the SRV website. So without further ado, I would like to introduce our panel members, and I'll start with Jo. Professor Jo Ibrahim probably needs no introduction to this group. Jo's an academic researcher, teacher, and a practicing senior medical specialist in geriatric medicine, and he has over 30 years of clinical experience. He's also a producer, co-writer, and narrator of 3 short films about ethical issues in persons with dementia and ageing. In 2019, the Sydney Morning Herald Good Weekend recognised him as one of the people who mattered in 2019, particularly in relation to health. Melanie Joosten is a ex-colleague and friend, and is also the author of the paper we're discussing today. And she's the policy officer at Senior Rights Victoria, which is a community legal centre specialising in preventing and addressing elder abuse. Melanie has a Masters of Social Work and is the author of a book about ageing in Australia called A Long Time Coming, Essays on Old Age. And some, as you may know, she also writes books of fiction, which I also recommend you read. Elizabeth Libby Love has been practicing social work since 2002 and has worked as a social worker in Australia and in the United Kingdom in clinical areas including HIV, disability and aged care. She's currently employed as a senior social worker in St Vincent's Hospital Older People's Mental Health Service, and is currently the Elder Abuse Lead at St Vincent's Hospital, where the Health Justice Partnership is in operation. And finally, we have Dr. Patricia Reyes, who is Director of Medical Services at the War Memorial Hospital, Waverley, and Consultant Geriatrician at St Vincent's Hospital in Sydney. She's a clinical lead of the St Vincent's and War Memorial Hospital Health Justice Partnership, integrating legal services into healthcare. She's the author of the Australian and New Zealand Society for Geriatric Medicine's position statement on elder abuse. And her current research interests in elder abuse include evaluation of the health justice partnerships in the prevention and response to elder abuse, and investigation of screening tools to identify elder abuse in the acute geriatric wards. So as you can see, we've got a fantastic panel of covering both academia, clinical practice, and experts in policy. So Libby, if you can unmute, I'm going to start with you, because I think the place to first start is really, well, what are the issues from an older person's perspective? And I'm sure in your clinical practice, you get a very good understanding of that. So it's just like you, if you could describe for us some of the characteristics of the client group within your service relating to how they might be experiencing elder abuse.
Sure, thanks very much. Yeah, so we're an older person's mental health service, and our catchment area is the St Vincent's mental health area, which is the inner city of Sydney. And we see people who present with a mental health concern or diagnosis. And we have seen an increase in presentations where elder abuse is part of the kind of, I guess, comes with the reason for referral to our service. But thinking about sort of risk factors for people, older people who are at risk of elder abuse, the people tend to be socially isolated. They're experiencing a cognitive decline. They might be from a non-English speaking background. They may have drug and alcohol issues. They may experience loss, and not just in the typical kind of bereavement sense of loss, but loss of independence, or loss of accommodation, or loss of health as they kind of knew it, and that sort of process of aging. And I think looking at people experiencing elder abuse, there's commonly a dependence on the alleged perpetrator for something, whether it be for care and support, for accommodation. And as we know with elder abuse, nothing's black or white, and it's quite complex, because sometimes there's that reliance on the person who's delivering the care, who's also the potential perpetrator of abuse. And that's something that we sort of deal with in that. If the elder abuse is identified, then also what are the kind of repercussions for the person in maybe that their biggest concern is having to move into aged care, and actually as a result of the elder abuse being uncovered, that may be a direct outcome. And I think also just with that sort of decline in cognition and changes in mental health, that also kind of the risk factors for being susceptible to elder abuse can be heightened. And I think I'll speak about it a bit more later, but there's interesting sort of issues to grapple with diagnoses around sort of delusional disorders, or sort of whether there's psychotic symptoms, and also reports of elder abuse and where they kind of intersect, and how to kind of manage that. But that's some of the characteristics of some of the people that we see. And it's interesting, just in those opening kind of discussion where you talked about the elder abuse kind of bringing on a mental health issue, and thinking about different sort of cases that we've had de-identified, of course, where kind of in the end, the primary mental health diagnosis is something like an adjustment disorder as a response to severe kind of physical and emotional abuse. And in fact, if it hadn't have been for the elder abuse, it would likely have not been a mental health diagnosis.
Yeah. So it's complex interaction, isn't it, between risk factors and consequences, and psychological, social, physical health issues. Patricia, perhaps I could ask you to elaborate on that a little bit more, about what you're seeing in terms of the risk factors for poor mental health in this cohort.
Yeah, so Libby and I practice in the same area of Sydney. My practice spreads across acute geriatrics, so I see patients in hospital. I see them when they're recovering, when they're in rehab, and then I follow them up in the community. And I actually work with an outreach team called the Geriatric Flying Squad. So we then do home visits, and we see patients in their own environment. By and large, and this may be a bias because I am a physician, the most common risk factor I find in this cohort of patients is the accumulation of illness. It's that multi-morbid older patient who becomes frailer and frailer due to accumulation of disease. And as that frailty worsens, the dependence worsens, and it then becomes a vicious cycle. They become more dependent when you feel physically unwell. I find that mentally that unwellness follows. They have poor well-being. How do they cope? Well, sometimes anxiety and depression will follow. They might find coping strategies in alcohol, which introduces another mental health issue of substance abuse or misuse. They might become reliant on sleeping tablets. They start falling over. They have injuries from the fall, and then it creates more dependence. So it's that vicious cycle of increasing physical unwellness, bringing on mental health issues. And as Libby's pointed out, then all of those intersect to become risk factors for abuse. And as you said, I actually find that it's quite complex, and no one treatment is actually enough to fix that, given the complexity of the risk factor profile. It's not about one tablet fixing their depression. Antidepressants only make older patients fall over more. It actually doesn't just fix the depression. A lot of patients will come to me asking for a tablet as a quick fix, and it's never a quick fix in geriatric medicine. It's most often multifactorial, and so is the risk factor profile.
So if we can just unpack that a little bit more, that risk factor profile. So talking about increased frailty and increased dependency on the perpetrator. So what's the actual relationship between that and the trigger for that turning into abuse?
Many factors. Family dynamics would be one risk factor that I find there, where previously the parents would be the authority figure in the family, and as that dependence changes from parent to child, child to parent, that power dynamic changes as well, and it's a big risk factor for abuse. People who've had a long history of, say, for example, domestic violence or exposure to domestic violence when they were children, and then that dynamic changes. A long history of trauma, for example. I also look after people from an Indigenous background, from the stolen generation, for example, where some of these ingrained traumas may have been manageable throughout their adult life and tend to resurface as they become older. That's also another risk factor that I've noted. And then there are those cultural and language aspects where, as perpetrator, or previously, if you were the one perpetrating abuse, when that dynamic changes, you might then be the recipient of it.
Yeah, I remember interviewing someone for my PhD who described that as the worm turning, that her husband had abused her throughout their adult life, and then he became dependent on her. Yeah, complex dynamics, as you say. Jo, I might turn to you. There's been a lot of focus on aged care, particularly residential aged care recently, as we all know. From your experience as a geriatrician, what do you see as the main mental health issues facing older people who are living in aged care?
Hi, Briony. Thank you for asking. I have a set piece which I might go through, which will stay within the short time span. I wanted to touch on some existing mental health issues, the change in life that occurs in going to residential care, the nature of dementia, what life's like in residential aged care, the fact that it's at end of life, and the trade-offs become far more important. So I'll cover those 5 points really fairly quickly. So what we know is that older people, particularly those in residential aged care, have a high prevalence of anxiety and depression. And it's somewhere between, well, anywhere between 20 up to 60 or even 80%. So the quoted rates are really vary enormously. The studies that have looked into the treatment of people with anxiety and depression show that it's under-recognised. So people that have it aren't picked up, and those that are picked up with the diagnosis are undertreated. One of the issues with the undertreatment goes to the lack of recognition that older people in residential aged care should have the same rights as those in the community. And it was only, I think, 2 years ago that the government made a song and dance about providing additional psychological support for people in aged care that was already available to those in the community. So accessing psychology and psychiatric support is much more difficult in residential care. The other issues that occur as we all get older that Patricia has touched on is, as you get older, you accumulate. And so if you look at your house, you accumulate things. If you look at your body and your mental health, you accumulate diseases with each decade. So by the time you get to 80 or 90, you've usually got 4 to 8 conditions that you've accumulated. And these really impact on your function and impact on your independence. And so those specific changes in life mean that you're more reliant on others, you're less able to do what you want, and you've got to be more considerate of what others say to keep them on side. And so when you enter aged care, you've already got that setting. But once you enter aged care, you've left your home, you've left your community, so major stresses. You've left your network behind of people that you know and trust and who you can get informal advice, and they're not always visible to others. And you're having to cope with a disability, usually an acute illness that's come on, that's meant that you've had to move to residential care. So you're coping with substantial life stressors, which and you don't have the same social network. And the majority of the community don't recognise that these are significant life stressors. and expect that as you get older, you know these things are going to happen, so you should be able to cope with them because you can see them coming, which is never true. The other issue, so the third issue then is the prevalence of dementia, and at least 60%, if not 80% of people in residential care have cognitive impairment or dementia. With dementia as a diagnosis often comes depression, and having to adjust to that. And often the stigma attached to dementia that your life's not worth anything also colours the decision-making and support that the people around you have. And there's a lot of research that says that people who don't have dementia think that life with dementia is terrible. And people with dementia, when they're asked, their life isn't as bad as others make it out to be. So there's a real mismatch there. So you've got all of those sort of personal and social community attitudes. Now, what I want you to do is imagine that you're in a residential aged care facility. It's now regimented compared to the freedoms that you had at home. It's not inclusive in terms of the community. You don't really have that much freedom to come and go as you please or contact people as you do. And if you start to make friends and build a social network within, then the staff turnover is anything from 5 to 20%. So if you make friends with 5 staff, one of them will leave for sure during that time. And if you make friends or build a social network with other residents, 1 in 3 of those residents will die every year. So you establish a social network which then goes. You then got more grief and bereavement to consider with the losses that are occurring in that setting. The fourth point, and it sounds terribly depressing, you're then at end of life. So the average length of time people spend in residential care is about 2.5 years. And so the community, your family, your friends, everyone expects you to be dying. And so the amount of time and energy put into planning things for the future is really limited, and future planning is really about estate management and how you can die nicely. It's rarely about how you can live well. So all of these factors now combine into a situation where you've got nothing left to trade. And the only thing that you want to see is, if you want to see your family or if you want people to be nice to you, then almost invariably the older person simply concedes and agrees, or agrees with whatever's proposed to them so that they don't lose the last strands of engagement or people around them. And so they can't negotiate. You may think they say what they've got no filter and will say whatever it is that they think. And they may do that on general issues, but on issues that impact on their psychological well-being, their emotional, financial, all of those issues to do with their personal safety, they will almost always trade off to make sure that their network remains around them and don't have the, as Patricia pointed out, don't have the energy to fight. And so, you know, the people that you see in the streets whining about the freedoms with COVID, so you know my attitude straight away about that, are young people who have energy to go to the city, wave banners, shout and be physically active. Again, if I'm 85, 90 with dementia, arthritis, my life is looking pretty bleak. I don't have the energy to protest. And what I want is peace of mind. And I want people to see me and visit me. And so from that point of view, very, very vulnerable are older people to anything, which, because they've got nothing left to trade. You know, so sure, you can have my money, sure, you can, all of those decisions are really, they concede, I think. And so you're left with a really difficult situation in residential care. And I've not touched on the vulnerability that they have towards staff. You know, so these things still happen even if we had 100% of staff that are angels.
Yeah.
And we don't have 100% that are angels.
No, precisely. I mean, it's a bleak picture that you paint, but I think it's a picture that's realistic, and many of us have experienced with family members as well as with clients that we work with. And at the end of one point, we will get to talk about some solutions, but we might leave that, I'll put that on pause. But I just reflect that at the point at which people most need advocacy and mental health support, it's the least available to them, which I think is where you started.
Yeah, it is. I might just take this up 30 seconds.
Yeah, sure. No worries.
Although the advocacy, so being able to access advocacies, I've frozen. Never mind.
We can still hear you, Joe. I think.
Okay.
Yeah.
I was just going to say, in terms of getting advocacy, in the modern world, you've got to be IT literate, and you've actually got to understand that an advocacy service would exist, that they would represent you, and that you know how to get them. And these organisations did not exist when our grandparents or parents were growing up. So it would never cross their mind that there would be a service to help them for nothing.
Yeah. Thanks, Joe. I'm going to ask Melanie now. So Melanie has written this great paper that I commend to you. So Melanie, I'd like you to expand a little bit on what you've put in the paper, particularly around the intersections between mental health and elder abuse.
Thanks, Briony. And a lot of those intersections have been covered by the other speakers, which really shows how this happens in different contexts.
Sorry.
Is that all right? Yeah. And so this paper grew out of, in Victoria, there's been a Royal Commission into the mental health system and an acknowledgement that it's not working. And what we wanted to do, having read that huge report that came out of the Royal Commission and the recommendations, is that we wanted to highlight, I guess, what we see at Seniors Victoria with the clients who come in and their interactions with the mental health service system. And the different ways that the failures of the system really impact on people. And so there were kind of three main intersections that we wanted to highlight with this sort of broad brush paper. And that was looking at how older people who themselves are experiencing mental illness can become more vulnerable to abuse, as the other speakers have sort of discussed. And from little ways of being unable perhaps to make decisions in the moment, or being reliant on others for care, or dependent, or as Joe sort of really aptly described, that agreeing to anything in order to keep people around you, keep you happy. And we see at our service where people have done that with money, with gifts of property, of loans of money, or gifts of money, or just allowed things to go unchecked, the sort of behaviours that anyone else would be up in arms about or might go to the police. They've sort of let that happen, particularly when it's a family member. And people who, you know, I mean, there's so many different mental illnesses that might affect a person, but also the way that it can kind of affect them is when people are unable to perhaps make decisions and rely on others too much for care, and then also become very socially isolated and don't have other people in their lives. And particularly for people who have had long-term mental illnesses throughout a lifetime, they might have really lost a lot of those relationships where someone might have been able to step in or assist. And so the second intersection, and one that I think isn't really discussed all that much, is just the real effect that elder abuse can have on a person. And so, you know, the traumatic experience of the abuse itself can lead to anxiety and depression and stress. And it might be a trigger for some of those really difficult mental illnesses that might happen later in life, where, as Joe has said, you've accumulated all these other challenges and age-related sort of illnesses as well. And there's been like some really significant research to show how older women in particular who were leading very healthy, happy lives before experiencing abuse suffered a decline in their well-being and physical health, from which they did not recover well after the abuse. So one of the things we wanted to look at was how the mental health service system could better support people who have experienced abuse through peer support groups and things like that, none of which were kind of looked at by the Mental Health Royal Commission, but some sort of really simple things that could be done for this particular cohort. And then just the third way that was really interesting, and it's kind of a little bit of a separate issue, but one of the major ways that our clients interact with the mental health service system is as carers of a family member who is experiencing mental health issues. And so it's often an adult child who's living at home, and the person, as they're getting older themselves, worried about their own future, is worried about the child's future and how they can support their child, particularly for those who don't want help or are not in position to seek help or treatment themselves. So they're the kind of three major areas that we sort of wanted to bring together in this paper.
Thanks, Melanie. So just picking up on that last point, I'm just interested about, like, there's often a kind of belief in the broader community that elder abuse occurs because the carer is the perpetrator. And I think the example you were giving there was more that the adult child who's relying on the older person as the carer is the perpetrator. Can you just explore that a little bit more, that, you know, what's going on in the care relationship?
Yeah, what we often see is where we've got an adult child who is perhaps experiencing other stresses in their life, and mental health is one of them. Sometimes it might be substance abuse, sometimes it might be a relationship breakdown or gambling, these sorts of other things, and they return home to mum and dad, or perhaps they've never left home. So they're not at home in order to care for their aging parent, they're there being cared for. And it might be in a really kind of just the sense of them being at home, of having nowhere else to go, and the parent offers that, or it might be that they do require a lot more from the parent. And then the difficulty that we see when clients come to us is when that relationship has just become very conflicted. When the perpetrator, particularly in terms of mental health, perhaps if they're not seeking treatment for the mental health issues that they're experiencing, then that can be really difficult and traumatic for the older person to sit by and watch, or to kind of have to deal with sometimes some of the behaviours of the person, or particularly if, it can just be a very complex situation. And I think that sometimes what we don't explore enough is just all those ins and outs of the parent-child relationship, the kind of feeling of parental responsibility. This is a person I brought into the world and that I brought up and I need to be there for, but also wanting them to be independent, wanting them to be well, but also wanting them to stop behaving in the way that they're behaving towards the older person. So it's a real sort of push and pull scenario, but not necessarily that the younger person is providing any care.
Thank you. So I might go a bit more deeply into some of the risk factors for mental illness amongst older people. And Libby and Patricia, I might bring you back in here, or Joe, or Melanie, anyone who'd like to hop in. So one of the things that has, again, been talked a lot about lately is loneliness and social isolation. How much are you seeing that as an issue for the people that you're working with?
I see it quite often, and both phenomena are interesting, because loneliness is subjective. It's that negative feeling of minimal contact with others, and then social isolation is the actual loss of that contact. And people sometimes equate them, but they don't necessarily coexist. You can be lonely and not be isolated, and vice versa. What I do know is that from this pandemic, where the isolation was thrust upon us because of COVID restrictions, patient after patient in clinic have complained about losing that social network that Joseph was alluding to earlier on. And interestingly, as rates of loneliness and isolation have increased, and I think one recent survey from Relationships Australia showed it was about 1 in 3 older people with complain about this. Anecdotally, I see it much more often. And interestingly enough, in parallel, there is increasing research that longevity and aging well is associated with increasing social connectedness. And so it's that loss of social network that then worsens the social isolation and feeling of loneliness, which we've previously discussed then intersects with poor mental health. To a frail older person, that routine, even to the older person who's starting to dement, they feel security in that routine of theirs, which includes social connection. That walk once a day makes all the difference to someone who becomes quite physically deconditioned and not. And so I find that loss of social connection impacts significantly on both physical and mental well-being.
Yeah, thanks, Patricia. Joe or Libby, do you want to add to that?
Yeah, if I could, I think that what we understand of social inclusion is not very sophisticated at the moment, particularly in, I think, in aged care and in medical circles. And you tend to think that if you see a visitor with a person, that they're now socially included and that they're happy. But there are many times where you get a visitor that you don't want, which doesn't mean that that's treating your loneliness. What that's causing is far more anxiety. And what we tend to see clinically is that the family and friends will flock when the person is sick and then disappear the minute they stabilise. And they flock again if you're making a decision about residential aged care because of concerns about where the assets are going to go. And then if someone's close to dying, people flock again to clear up a lifetime of misunderstandings. So I think that the idea of social inclusion requires a lot more work to understand what does the person actually want and how do they feel with the different people or the connections that they have. What are they getting out of the relationship? You know, the preference is always to see the grandchildren, never the children. And one of the issues with elder abuse particularly is a lot of the patients that I've seen tend to bear the brunt of it rather than have criminal charges against their children. And they also feel responsible for the bad behaviour because it's their child that they've raised. The final thing is that we've got to be really mindful that the research into elder abuse is heavily tilted towards financial because that's far easier to count and measure. And so the perpetrators of financial abuse may not have the same characteristics that you would find in other areas.
Yeah. Thanks. Libby, I'll come back to you in a minute. I have got a question in the chat, though, that I wanted to put to Melanie. So, Melanie, the question is, does the report include experiences of older LGBTIQ plus people, and how might this be different from other people's experience? For example, the impact of discrimination, stigma, etc.
Thanks for that question. This report doesn't particularly look at those. We wanted to do a really broad brush, just looking at older people and the experience of elder abuse, and sort of taking into account all those different intersections and things like that. We have done an earlier discussion paper that is specifically about gender, sexuality and elder abuse and the different ways that discriminations, both from a lifetime of discrimination for many people from the LGBTI communities, would experience kind of come to impact on their experiences of elder abuse within their own families, perhaps families that they've left, or from ways of loneliness and isolation where they might find themselves in aged care where there's no recognition of their sexual or gender identities and things like that. So I think there's so many issues that could be brought into it. In our client base, and I think this is sort of a failing of our service, is that we assist people who reach out to us and contact us through the helpline, and we don't see a huge number of people coming from those LGBTI plus communities. It's something that we're trying to work with some other organisations more to kind of build those relationships and things like that. So it's not something that we're seeing a huge amount in our service cohort, but it's something that we're very aware of and trying to do some more work.
Thanks, Melanie. Yeah, I mean, I think there are some very specific issues for people from those communities that have specific characteristics like identity, denial of identity and that sort of thing.
And particularly with the mental health system as well, obviously, with, you know, lots of aspects of that having been criminalised in the past or pathologised in the past. So I think that it's, huge amounts.
Did anyone else want to comment on that? Libby, Patricia, Joe?
I'm happy to comment in terms of residential aged care. With the LGBTIQ population, the historical abuses and the rejection of who they are really is still very, very recent, and a lot of that damage was done by the charitable and church groups, who are now the ones that are providing care in older age. And I saw a quote somewhere that you know, that people feel like they're going to be recloseted by going into aged care with these faith-based organisations, and they don't feel safe in that environment. And I think it's a serious concern about how do we manage the care of people that have been traumatised as children or traumatised because of their gender identities. Now, with the vast majority of aged care homes really are still faith-based and charitable, and the institutional setting creates great damage, and I don't think that that's been given the airtime or the attention that it deserves.
Yeah, it's an interesting question, Joe, not just for residential aged care, but aged care services generally. I know my mother-in-law wouldn't go to palliative care because it was run by Mercy. So she thought that they'd have a particular, Catholic approach. What her words were, they won't let me die, you know, they'll keep me alive. I don't think we've ever really explored enough what the perspective of the older people approaching care is to all those different faith-based groups. But yeah, I think it's an interesting issue to explore a bit more. So another risk factor, I guess, is cognitive decline and dementia, and we've talked a little bit about that already. But I'm just interested, and Libby, I might go to you here, about more the intersections between cognitive decline and mental health and elder abuse, that kind of intersections.
Yeah, I think with cognitive decline comes, for some people, and this is just speaking generally, can be a vulnerability to potential exploitation or reliance on people for care, which in turn could increase the risk of being susceptible to elder abuse. I think looking at like, if you're having symptoms of a mental health presentation, be it depression or anxiety or psychosis, and I guess you'd have an increased risk of experiencing elder abuse. But thinking about certain sort of cases that or people that we've come across, it can be really difficult to kind of decipher what comes first. Thinking about a lady who was experiencing severe physical abuse, she did have some cognitive impairment, mild cognitive impairment, and for her it was a carer who was perpetrating the abuse, but it was actually being in a health setting and being in a hospital setting where she had that time away from the alleged perpetrator. And then I guess that kind of comes into that question around sort of social isolation, not having people to be able to kind of make contact with, to trust, and to be able to speak about if you wanted to disclose that something was happening. But it was actually being away from that situation where she was able to disclose. But as I was saying, she's someone that wouldn't typically have fit into our criteria because she didn't have a diagnosable mental health issue. But there's definitely an argument to say that based on the trauma and abuse that she'd encountered, that she had developed mental health concerns that did make her sort of eligible for our service. But I think it's a complex area. And again, with sort of when we classify delusional kind of thinking or beliefs that we're not necessarily agreeing based in reality, that can be really, really difficult if you're somebody who has a diagnosis of dementia or a psychotic sort of illness, and they're presenting, also saying that they're experiencing some form of abuse, and how to explore the abuse as well as kind of treat the psychotic illness, and teasing that apart and ensuring that you're still approaching it in the way you would with anyone who's reporting any kind of abuse. Yeah, so it's all, again, very kind of
yeah, it's the whole
complex
credibility issue. Yeah, yeah. Joe, would you like to comment on that as well?
I'd be interested in Patricia's thought. Clinically, we often face dilemmas where the carer is the perpetrator of what would be considered elder abuse, but without the carer, the person couldn't live at home. So if I leave the house, deadlock it, so my partner with dementia is trapped in there, does that constitute elder abuse? Where I think there are some real difficulties about where this sits ethically and morally. When you've got two people both with dementia, the one with mild, and you want to keep them together, and the behaviours of one is impacting on the other. What do? Do you split the couple because that one person would receive the better care that they need, because you can't negotiate with the other person that's got mild to moderate disease? Who makes those decisions, and how do you work through them to know that you're at least trying to think through it? And we face these dilemmas clinically quite often, and sadly it's the pragmatic. What happens is the pragmatics of the situation. It's almost like no decision is made. It's only what services are available, or if there's a threshold. And I wonder if Patricia's probably got some more examples clinically where you're stuck.
I do. It's not a list I'm proud to have, because it gets longer and longer every day of clinical practice. It brings us to that problem of behavioral and psychological symptoms of dementia in managing those behaviors, which, if they include psychotic symptoms, it's a chicken and egg thing. Are the reports of abuse a consequence of the psychotic symptom of dementia? Are they paranoid because are they actually getting robbed of their money, or do they just think they are, which is what Libby touched on. But more often I find that it's those difficult behaviors, the repetitiveness, they become so annoying and they're very hard to look after, and it's that stress on the carer that then becomes the biggest risk factor for abuse. And it's a good discussion there, because then I think it segues into what we'll be discussing next around resourcing, because in that context, in that clinical example, it's about putting supports in place for that carer to minimize the stress. And then you come into that question of, well, who makes the decision about who's allowed in? Because then there you have another example of people wanting to be fiercely independent, being resistant to services. We already have a paucity of services, but then you have those cohort of people who won't even have any form of services because they're afraid of strangers, because there is already that grumbling level of paranoia. In an ideal world, we would be able to service all of these issues, whether or not it's social need. Is it need for a companion to actually just walk them through the day? Do they actually need help with managing their finances? Do they actually need personal care help? And it's about customizing and tailoring that support that we can put in place to actually address a complexity of needs.
Can I just add one scenario to just highlight? I guess the question is, what would people do if the patient you have is a male who's had a major stroke, who was a perpetrator of family violence? His wife talks to me and says, I'll have him home. And I said, I don't really understand why. He said, I'm going to have him home because he'll get his dinner when I say so now. What do you do in that situation?
I would introduce a third party.
Practitioners.
Yeah, and that's happened. I actually have one specific case like this. And what we do is we introduce an independent party. So it's not all up to her when he eats, because there is that oversight, if you want to call it that, or at least another support system, another tier of support that's in place. So although you allow her some control, they don't have full control.
But she could simply say, I'm not having him home because he requires too much care.
In which case they go to residential aged care and they get the supports there.
So you would trade you would trade residential care rather than home with a partner that sounds like she wants to exact revenge.
What I haven't mentioned is, where does the patient sit in all of this?
The patient wants to go home. But anyway, we're hijacking. We should.
Yeah, that's right. Yeah, this is exactly the complexity and the difficulty that you clinical practitioners face every day. We've got a comment, I think, so let me just read it. This is from Kathy Day. We provide counselling and residential aged care via funding from the PHN. Lots of issues come up. Re-dementia, we need to go back to the event that triggered changes to our system back in 2006. That happened to a person with dementia in an aged care facility. The family raised the behaviour change and were ignored for a long time. Sorry, Kathy, I don't quite get your question. I might have to get you to clarify that. Sorry, and this is further on, I think answering your question. I'd encourage a case manager to be appointed to gain trust of both. Okay, good. So we'll get on to our final question now, which is imagining a fantasy future. Because we haven't actually talked about the Victorian Royal Commission into mental health much, which was also a trigger for Melanie's paper. So if you can imagine a world in which mental health services were fully resourced to address the health needs of older people, what would that look like? And how would this impact on the abuse of older people with mental illness? I'll let you go first this time, Jo.
Thanks, Briony. I'll keep it relatively short. I think the biggest issue that we face is, again, a siloing of health practitioners. And so talking about mental health only, rather than saying that mental health professionals have a specific skill set, well, it means that they can manage both mental illness, but they can also manage cognitive or behavioural issues that arise with dementia. There's been, I think, a very unhealthy and increasing split that mental health won't address issues to do with people with dementia, saying that they've got an organic disease. And we see this again with the medical and clinical specialties. And so I think the future really requires us to reimagine what health professionals do and to start combining nurses with social workers and doctors with lawyers and nurses with lawyers and human rights people with physios, in terms of looking about what's the skill set that you need to navigate the problems of the future. And no amount of teamwork is ever going to compensate for having people with interdisciplinary skills. And I think that mental health is well underdone, and it needs to be part of the normal care that's provided. And as I said, the example I give always was from the early 2000s when I was at the coroner's court, and we were reviewing a case where a young woman with anorexia suicided. And she had presented to an acute hospital and seen by the mental health team who said that she wasn't sick enough mentally to require admission. And the general medical team saw her and said that she wasn't physically sick enough to require admission. But within 24 hours, she had suicided. So she was clearly unwell enough to require care.
Yeah.
And
Yeah.
with us trying to pigeonhole everyone, we don't deliver the care that's needed.
Yeah, for sure. Libby.
Yeah, thank you. Just to add to Joseph's point, in our team, we have, it's a multidisciplinary team with psychiatrists, psychologists. We had an OT, we lost an OT, social workers, nursing, neuropsychologists, and we've also had the Health Justice Partnership in operation since 2017, and that's with the integration of a lawyer from Seniors Connect. To integrate into our health system, and they attend our case conferences and offer kind of consultation and secondary consultation, which has been really helpful, and it's been a adjustment, I think, for health and for law, and that kind of intersection between health and law and how that looks. Also, we go into residential aged care facilities, and so we have a multidisciplinary team. We have 8 facilities in our catchment area. And there has been talk, over the years of, with different funding cuts and maybe not being able to offer that service, which I think would be such a shame, because the people that we're seeing, even though they're in a facility where often the talk is you'll be around people and you're going to have social engagement and social interaction, actually the people we see are very often very lonely and have high rates of depression and anxiety. So I think that sort of model, the integration of health, law and multidisciplinary team, and more community kind of outreach in whatever form that comes in, is something important for the future, and to continue to kind of provide that level of care for older people in wherever they are in the community, including aged care.
Yeah, integration. Patricia.
And sorry, can I just, as Justice Connect is the legal firm that's working. Sorry, I said Seniors Connect, but Justice Connect is where our lawyers come from. Yes, thank you.
I would echo both Joe and Libby's comments there. I work within a multidisciplinary team, very similar to Libby's team, and we actually work collaboratively. The Geriatric Flying Squad works collaboratively with older persons' mental health. We actually also have streamlined referrals with the paramedics, with the police, and in New South Wales, the New South Wales Aging and Disability Commission. So when it comes to responding to these cases of elder abuse, it actually takes a big team. But the only thing I would add really is, I think if we were ideally resourced, I think prevention is key. And so before it even gets to the stage where a team like mine actually gets called out to this case of elder abuse in the home, things that we could have worked on would have been financial literacy and education and awareness, and about getting your things in order before you actually got to the stage of frailty and dependence. I think is key, and that's one of the things we work on with the Health Justice Partnership, getting powers of attorneys, enduring guardians set in place, provided they do have a trustworthy person that can act and support their decision making, as opposed to being replaced. And so I think prevention is key, and in an ideally resourced world, we would be putting a lot more into educating the next generation.
Fantastic. Melanie, I'm going to let you have the last word before we hand back to Jenny.
I think that idea of early intervention, if the system is better resourced and people can seek treatment and get treatment early. We've had multiple cases at Seniors' Rights where an older person has tried to get help for their son or daughter who's living with them, and been told they're not unwell enough, and they've had to, go through the police to get an intervention order to get the person removed from home, all these sorts of extra steps, which then just add to the complexity and the trauma for the older person. And I think also in a well-resourced system, we would see that with our service, we work to address the elder abuse that a person is experiencing, but then to have more support for people afterwards. when they're trying to get their lives back on track, when, you know, the other services and things have moved on, to have better support to help the person get their mental well-being and health back on track, so that they're in a much better position as they continue aging.
Fantastic. Well, thank you, panel members. I'm now going to hand back to Jenny, who's going to wrap up the forum. So thanks so much.
Thanks, Briony.
Thank you, everyone. That was a great forum. I thought it was really rich in terms of the contributions and the thinking. So thank you, everyone, and I'm really pleased to have been able to host it and hear it. I think that some of the themes that came up for me, I'm going to not do the session best by trying to summarise it, but the issue about dependency and how that plays out, and the impacts of that, and that raises real questions about, well, how do we try and tackle that to prevent it and try and get things in place, and the issue about family dynamics and the history of family and relationships with couples and how that plays out, and that's again a tricky thing, and that relationship about which comes into that social isolation and trying to maintain relationships and the risks around that and what you trade and what you give up, and the instability of those social relationships where in that context. So I think that that's something which again is quite significant, and we again would be great if we could do some preventative work around that. And certainly the discussion around integration of professions, and people have given some examples of that occurring, is obviously something that's really needed, so we avoid those silos, and the early intervention and the aftercare. So the importance of that is with peers too. I can recall my mum when she was 93 at home saying, I think it's time I went somewhere else. I want to be with people my own age. Thinking, well, okay. And thinking, well, there's not a lot, Mum. So but that was really important for her, to have people of her own age that she could talk to. So thank you, Briony, for facilitating and hosting the session. It's been great. And thank you for our excellent speakers and contributors, Libby, Patricia, Jo and Melanie. And thanks to EAAA and Compass for hosting the session. And thanks to Gary Ferguson and Seniors Rights Victoria for organising it, and Katie Roy from EAAA for also helping to organise and provide all the IT support. I plug again, if you're interested in EAAA and trying to tackle elder abuse, please become a member. Just go to our website. And also we have the National Elder Abuse Conference, which we unfortunately had to hold over due to COVID-19, but we've had a punt to have it in 2022, February 14th and 15th. But it is a hybrid conference, so you can take part virtually, you can register, as well as attend in person. So I think that's all that I need to do, but thank you very much for that, for coming, and for all of you who came to hear this session, and thank you very much for the contributors for obviously giving this some thought and presenting and talking today. And I'll leave it at that. I hope you have a good afternoon. Bye.
Thank you. Bye.